So thanks to all of you for joining us today. I know that there are some additional people that are jumping online. Um, I have to say that we requested that uh, Kelly come back and give us more detail because she was one of our keynote speakers at a health equity symposium that we held late spring, early summer, and she's back by demand. Um, her talk was extremely well received. Her team did an amazing job. And frankly, I think when we planned the symposium, I think we underestimated how much they have to share. And we should have probably given them the full session and not just a segment of it. I've had the good fortune of meeting Kelly in the course of my new role here at the Health Sciences Office for the university. She is a rock star. She is impressive on lots of levels, and she has built an amazing team. I think just to put it in context as well, her office was established in 2021. And so, if you think about that from having worked in research or in an academic setting, what they have accomplished over the course of 3 years is phenomenal. And I think this report is an example of it. And I can also tell you from working with many of our investigators on national grants and submissions that we have to put in that really not only cover Erie County, which her office oversees, but also some of the other counties that are part of our Western New York region, what they have done to elevate the level of commitment to health and health equity in our community, and just their data is an example of that. It's very hard to compare. So they've distinguished themselves. We are very, very excited to have you back. Thank you for agreeing to do this again for us. But I am just being responsive to the crowd. So with that said, I'll turn it over to Kelly and her team so that they can share a little bit more of this massive body of work that they've started to put together on an annual basis. So thank you, Kelly.
Thank you so much for having me and opening up this space for these kind of conversations and to be able to share the information we have. Our first presentation, we brought more information than we had time to discuss. And so today my goal is to stick to the script and make sure that we get through all of our slides, all of the data. If you have questions, please feel free to put them in the chat or wait until the end when we open up for Q&A. I am Kelly Marie Wofford. I'm the director of Erie County's Office of Health Equity, and I am joined by Mike Weiss. He's our lead epidemiologist. He led the data collection and survey writing, report writing for our office. And so I wanted to make sure you heard from him. So you will hear from Mike in a few short slides. Just to give you a brief presentation overview, we're going to talk about just a little bit about the office, the project fundamentals within the office, and then right into the survey, discussing some survey demographics, social determinants of health, and the survey results themselves, and kind of close out with next steps and open up for questions. While survey results seem to be what it's the second last thing that we're discussing, it really is the lion's share of our time today, but wanted to make sure that we, just let you know where this conversation is going today. So our office, Jill mentioned, was established in 2021 by Erie County law. I actually, in 2021 means December of 2021. So we are truly looking at a short 3 years this December of existence. And the vision of the Office of Health Equity is for all people from disadvantaged, marginalized, and diverse populations in Erie County who presently experience higher rates of poor health outcomes to achieve maximum health and wellness. The office and the act that created the office outlines the key activities that kind of guide the scope and the type of work that is done by the Office of Health Equity. And to that end, we analyze health disparities. We understand and connect those factors, making recommendations to improve delivery and access. and to implement pilot model projects and programs and report and more reporting. So this presentation today kind of takes you really through the key areas that the law requires us to do, including the reporting and making recommendations, understanding the factors, and analyzing health disparities. So a little bit about the work of the office before we dive deeper into the health and wellness survey. We provide grant assistance. We lead mental health first aid trainings with the idea of changing the conversation around mental health in Erie County. Our epidemiologists provide technical assistance to community organizations. We also designed and distribute newsletters focused on like upstream issues within health and wellness. And these are written in the 6 languages, which ties our offices to language access. So the 6 languages that are most spoken and understood in Buffalo. Those are English, Spanish, Bengali, Burmese, Swahili, and Arabic. So those newsletters are available in all of those languages. We also review policies and make recommendations. For example, our breastfeeding, chest feeding, and lactation-friendly workplace program is one of those spaces that we do that in. We also have staff dedicated to Hispanic and Latino outreach and education, and our children and youth with special healthcare needs program, which is a federal program funded through federal dollars to the state, from the state into counties. And Erie County is the only county in New York State that has health equity as its focus within the children and youth and special healthcare needs program. One additional note that I'd like to mention is that we're very deliberate in our use of acknowledgments. Each of our reports that we produce begins with these 3 acknowledgments. We have a land acknowledgement that basically states this land was stolen. We have an enslavement and labor acknowledgement, which basically states people were taken and brought to this land, many of whom of African descent, who built the country that we are all living in, and that continues today through mass incarceration. And also a community acknowledgement, basically stating the work that we do. And if you look at my office, we are an example of this. Most of us come from community and community-based work. The work that governments, corporations, organizations, institutions do really is founded in the work that comes from community, and we need to be purposeful in acknowledging where we come from in order to better chart a path to where we're going. So one of the questions that comes up a lot is, how do we partner, right? Oh, you guys are doing this stuff. We want to partner. So we are all for partnership. And one of the first questions that we ask is, like, who's defined as community? Who is your community? Are we talking about anyone outside of the Erie County Office of Health Equity is community? UB, do you consider everyone not affiliated with UB as community? Are we talking about the everyday neighbors as community? Are we being specific and talking about a group of neighbors within a community or within a demographic that is your community? It's important to know who community is when you're looking to partner. We have communities of focus that are outlined in the law. Again, that for us in this space right now, we are primarily, while here for all Erie County residents, working within communities of focus that are inclusive of the Black communities, LGBTQIA communities, and rural communities. I have a saying, know your role, know your goal. While we can work everywhere and do all of the things, it is not necessarily beneficial for a group of 12 people to be working in all the places doing all of the things. So we're very specific and purposeful, not just in defining community and working within communities of focus, but also in creating and being transparent in that work so others can take it and run with it within communities that they are focused on. Partners really can be anyone that's doing the work to address health equity within the confines of the law that created our office, And so what that means is it can be an institution, it can be a faith-based organization, it can be other government offices, it can be block clubs, it can be corporations. It all centers on the work that's being done. And the biggest takeaway is we work by invitation only. And so you won't find us in places and spaces where we're uninvited. Um, our office talks a lot about our ownership of being government employees and what that means. When we leave here, we become community members, but in this space, we are our government employees. And so we know when we show up, we're showing up as the government. And when we never want to be in a place of creating harm or pouring into very valid reasons for mistrust by forcing our way into a space. A little bit about the survey and focus group timeline. So before we jump into the key findings, I told you guys I was going to fly through the first couple points. So we're getting to the good stuff around the survey. So before we jump into those findings, I just want to provide a brief summary of the timeline for the whole project around the Community Health and Wellness Survey. So in February of 2022, and I started December 22nd of 2021, we convened a community work group to help us in survey development with the design of the questions and intention of that work. The survey was written in March of 2022 and revised and edited back and forth with that group until May. Then for the rest of 2022, surveys were distributed and responses were collected at community events throughout Erie County. From March until May of 2023, the survey data was cleaned and basic analysis was completed. Now, roughly at the same time that this was occurring, we began holding focus groups within the communities of focus. From July until September of 2023, we conducted 14 different focus groups throughout Erie County within our communities of focus. And lastly, the analysis of the data and report was written at the end of 2023, having been released at the beginning of this year, 2024. And our focus group report, which we'll touch on a little bit later, will be released later this year. So up on your screen is a QR code and the link to the Health and Wellness Survey report. On this page, you will see that the report is available in one clickable link, or if you're interested in looking at the sections of the report, you can click on those links individually instead of just opening up the whole 324 pages. So I'm going to start, and again, please feel free to use the chat function for questions. I'm going to start by discussing some of the basics of the survey, and then I'll talk about some of the demographics of the survey responses. So the 2023 Health and Wellness Survey was intended to explore the challenges and barriers to health that individuals in Erie County are facing. It contained 41 questions that asked them about demographics, health behaviors, and the social determinants of health. The questions were mostly multiple choice, often where the respondents could select all that apply. An example of this type of question would be shown down on the bottom left, where we asked lack of transportation has been a barrier to, and select all that apply. So for for example, someone could select that lack of transportation has been a barrier to accessing medical care and buying food and other needed goods and recreation. On the right, you'll see an example of a Likert scale question. You guys are familiar with Likert scale, so I'm not going to dive deep into that. And those were the two main types of questions that were used within this survey. Before we talk about the survey demographics, and we'll do that in just a moment, I wanted to mention how we collected the surveys from the community. So of course, we use the internet, and we posted the survey online. We shared the links and emails to take the survey with as many people possible. But also the office made a significant effort to go out into the community directly where people are at. So over the course of about 6 months, our community engagement team went to fairs and festivals and events throughout the city and county. Additionally, our office partnered with the Buffalo Center for Health Equity and the Witness Project for survey collection. We have the QR code up on the screen now for Witness Cares and the Witness Project if you're interested in learning more about the work that they do. For this survey, the Witness Project staff collected responses mostly by going door to door within the east side of Buffalo. So on the slide, you have the maps that represent where and how many surveys were collected by both the Witness Project and by the Office of Health Equity. They show the numbers of surveys collected based on the zip code of the person completing the survey, not where we were collecting responses. You can see that the map on the left, the Witness Project mostly convened or received surveys from individuals that lived within the city of Buffalo. And then on the right, you'll see that the OHE team also collected mini surveys within the city of Buffalo. But in addition to this, we also collected surveys from people living in nearly all of the zip codes in Erie County. There were only 2 zip codes in the county where we were unable to collect any responses. One is 14260, which is part of the University of Buffalo. And actually, no homes or residences exist within that zip code. The other zip code without responses was zip code 14069, which is the Glenwood area near Colden. And according to the census data, less than 800 people live in that specific zip code. But in total, we collected 3,451 responses, with 1,028 of those collected by the Witness Project and OHE collecting 423, so 2,423 surveys. So those maps told us a little bit about where people lived that completed the survey. The survey asked additional questions about the respondents' demographics, such as age, race, ethnicity, gender, and sexual orientation, as you see on this slide. Now, the bar chart on the left shows the ages, the age groups of the survey respondents. The age of the respondents was spread across all of the age groups, with most respondents being 30 to 39 years old and 80 plus having the least number of respondents. In the center of the slide, you can see our respondents by race and ethnicity. For race, the largest group of respondents selected was white, with 1,445 respondents. 1,389 respondents were Black. After that, the next highest group is more than one race, with 111, and then Asian with 107. The survey did break out those that selected Asian into 9 additional Asian countries of origin options, including India, Bangladesh, Burma, China, Philippines, Japan, Korea, Pakistan, and Vietnam. But as our efforts to account for as many people as possible, we are not able to do that to this degree in our report out, because most of the Asian subgroups had very few respondents. So we had to roll up those responses into the larger group. So in many of the results and visualizations that we show you today, the Asian subgroups were combined back together to present that group as one single group. For ethnicity, 269 respondents were Hispanic, or about 8% of our responses. And like Asian, we broke out Hispanic place of origin, but also like Asian, Hispanic subgroups had very few responses in general. So we rolled up that data so that it was all presented at once, or as one group. Our survey also asked about sexual orientation and gender identity. For gender, most respondents identified as male or female, but other gender identities, including trans, non-binary, and gender non-conforming, were presented in the survey responses. And for sexual orientation, most respondents identified as straight, but we did get a variety of responses there as well. And Mike, yes, the screen share is working.
Okay, good. I just saw a message that it wasn't showing up, so I wanted to confirm.
So before we move further, screen sharing is working for me. Is screen sharing working for the rest of you all?
Yep.
Yes, okay, great. So we have a few more demographics to share with you. On the top of the slide, you can see that most respondents were born in the US, but 105 were born in US territories, and 218 were born outside of the US. On the left of the slide, you can see that respondents have reported all levels of education, the highest number indicating that they had high school, a high school degree or a GED, for the second largest group being those with a bachelor's degree. And then right below that, you can see employment of respondents. At first glance, this looks like a pretty large number of respondents that were unemployed. But another survey question that isn't shown here asked about the reason for unemployment. And with that information, we know that a large number of those who reported being unemployed were either retired or students, so not actively seeking employment. In the middle of the slide, you can see history of incarceration. 306 respondents indicated that they had a history of incarceration. And then right below that, you can see that 618 respondents reported a disability and 173 had a history of military service. So this brings us to the rest of the survey. In the report, they're presented within each of the 6 domains of the social determinants of health. On this slide, you can see a quick visualization of those 6 domains: economic stability, language access, community and social and community context, education, the healthcare system, and neighborhood and built environment. We took the time to present the results of the data within the sections of social determinants of health. So we're going to discuss the findings of the survey with this lens. Everything was broken out through and expressed through one of these 6 domains. And Mike is going to begin by sharing the first 3 of those domains, and I will finish up. Mike?
Great. Thank you, Kelly. So I'm going to be starting off with the economic stability domain. And so some of these visuals that we're going to be showing, a lot of them are based on this financial situation question we asked. And we were pretty deliberate in not asking about an income dollar amount during this specific survey. Instead, we asked this question, which asks, which of the following best describes your financial situation? And so we have those options listed there. And then each of them, for visualization's sake, were kind of abbreviated. So we end up with not enough money, just enough money, or more than enough money, kind of the 3 categories of financial situation that we use throughout the report. And so on the bottom, we have a series of pie charts there for you. The first one on the far left represents all respondents. And so you can see that 37% had more than enough money, 45% just enough money, and 18% not enough money. But as we start to kind of look at that by certain characteristics, we have veterans, and you can see kind of a polarization that happens with veterans, where you see a higher number of more than enough money, but also a higher number of not enough money. So a little interesting thing there. Then we have individuals with a history of incarceration, where more than enough money is much lower than the overall response rate. And then we have the financial situation of respondents with disabilities, and just like history of incarceration, a much lower percentage of individuals with more than enough money, and above a higher number of not enough money represented in that group.
Mike, before you move forward, if you can go back to that slide, but also click this little floating thing at the bottom that says stop sharing or hide. If you can click slide.
I can't. I was trying to, but it won't let me.
Okay. So if you can
yeah,
just let folks know if you're covering something, those percentages are covered up so they can't see what those percentages are.
Sorry about that. For some reason, it won't let me click on that screen at the moment. The next thing we'll show is the percentage of respondents that had more than enough money, and we did this by zip code. And so the darker the green color, the higher the percentage of that zip code that responded that they had more than enough money. And so probably not all that surprisingly, the kind of first ring suburbs had higher percentages of reporting more than enough money. You can see kind of the north towns, and then out into our south towns are the darker green colors. with the city of Buffalo and actually many of our most rural zip codes being the lowest percentage reporting more than enough money. But I do want to kind of be transparent in that these rural zip codes do have the fewest number of responses as compared to the city of Buffalo. So the accuracy of kind of those that information is we wouldn't want to extend it too far, but we do see that kind of the two areas with the lowest reported amount of more than enough money is the city of Buffalo and some of our rural zip codes. Another question that we asked was based on kind of what they have in terms of hopes for their financial situation. And we gave a variety of options. This is one question where they could select all that applied to them. So they could say that they're comfortable with their financial situation, they had a plan, I'm aware of resources that may help me, I would like to improve my financial situation, but don't know how. And then I know how I could improve, but don't feel I have the necessary resources. So they could select more than one of them. And you can see how they were abbreviated in the key there. Overwhelmingly, most people, the highest selected was I have a plan. After that, it was I don't know how, followed by comfortable. But when we start looking at the specifically how people responded to that they were comfortable with their financial situation, we can see that that changes based on different demographic factors. So individuals that overall responded, so our total number of respondents, 18% selected that they were comfortable. But when we looked at just our LGBTQ plus population, only 14% were comfortable. And then if you look at people of color, only 10% in that group felt that they were comfortable with their financial situation. And furthermore, 10% of the trans, non-binary, and all other gender identities group stated that they were comfortable. So you can see as we change demographic factors, that rate of feeling comfortable changes. And then the last data point within economic stability that I wanted to kind of show was the respondents with any mental or physical health conditions by their financial status. So within the survey, and we'll kind of show this again later on, we asked a question about if they have any physical or mental health conditions, and they had a list to select from, and they could select all that apply. Anyone who selected any of the health or physical or mental health issues on that list were kind of grouped into any mental or physical health condition. But then the other kind of option in the other group was that they didn't select any of them or none of these. And then we can see here on this slide that financial situation impacts whether or not you fall into that physical and health conditions. So having more than enough money, only 60% had any physical or mental health issues reported. But when you look at not enough money, 76% of that group. So this helps shows that correlation between financial stability and health outcomes. All right, so we'll move to the next ECDOH domain, which is access, healthcare access. In this domain, we asked questions about the challenges to accessing healthcare. We also asked about treatment by healthcare providers. And then we also have some health outcome questions that I just kind of talked about. And we also did have a few questions about COVID. We asked respondents to answer this question. When I receive medical care, I feel that the providers respect me. I feel that the providers believe me. The providers speak to me in a way that I understand. I feel that providers are competent in treating people like me. And for each one of those responses, an individual was asked to use the Likert scale going from never to always. What we then did was convert those responses to a numerical value, as you can see on the screen. So never was given a 0, rarely was a 1, and so on. And then for this particular graphic that we're showing here, we actually did a combined treatment by providers score. So we averaged their response to all 4 of these questions. And then additionally, for this specific image, we have that broken out by educational, highest level of education. And so here you can see that pretty much as educational level increases, as formal education increases, the respondents' perceived treatment by provider also increases. On the left, we have some additional values that are using the same metric where we combined that treatment by providers, but this time we broke that out by race. And you can see we see a difference based on the race of the respondent, with white and Asian respondents reporting the overall highest average treatment by providers, with our Pacific Islanders or Hawaii natives being at the lowest end of that treatment by providers. Additionally, on the right, you can see the percentage of respondents that reported health conditions by race. So Black respondents were most likely to report that they had only physical illnesses, while white respondents were actually likeliest to report the highest rates of anxiety and depression. I should be more specific, anxiety and depression alone. So that means they didn't select any other mental or physical health conditions other than anxiety and depression. And then Asian respondents here actually had the highest rates of reporting none of these health conditions. Here you can actually see the list of health conditions that we provided, at least the top 10, in terms of numbers of responses. Anxiety and depression was the most often selected health condition, followed by high blood pressure. And so when we look at these, and then we looked at another question which asked if they had any challenges to accessing healthcare. And individuals that said they did have some sort of challenge to accessing healthcare were much more likely to report experiencing health conditions. So 77% of respondents who had one or more health challenge to accessing healthcare also reported that they had one of the health conditions that we listed. By comparison, only 61% of respondents who reported access to healthcare was not a challenge, reported that they had been experiencing any of the health conditions. All right, and so moving on to the next SDOH domain, this is going to be about education. Mainly the variable we used for this was a question that just asked for their highest level of educational attainment. And the options are kind of listed out here in the key below. They also correlate to the color spectrum on the figure that I'm presenting here. And here we're looking at a breakdown of educational levels by race. And you can see here some interesting findings. White respondents had the lowest percentage of did not finish high school. Black respondents had the highest percentage of high school degree or GED. But what is really pretty interesting in this is that, as Kelly had kind of talked about, is our combined Asian category shows this polarization between having both the highest percentage of did not finish high school as well as the highest percentage of a postgraduate degree. So when we kind of dove into this even further, what you actually start to see is when you use that breakout of Asian race groups into the Asian country of origin, all of our Asian respondents that listed their country of origin as China had a college degree. Granted, these are small numbers, which is why we're not presenting them independently. But on the other hand, the 69% of Asian respondents that were from Burma did not finish high school. So that's kind of how these results end up looking like this for the Asian category. And just a few additional notes at the bottom of the screen there. Hopefully you can see that with the thing popping up. But 62% of respondents with a disability had no college degree compared to 45% without a college degree or without a disability. I'm sorry about that. And then 82% of respondents with a history of incarceration had no college degree compared to 46% of respondents with no history of incarceration. And on this slide, we are showing the percentage of unemployed individuals by education level. And so this does exclude anyone that was younger than 18 and respondents who were indicated that they were retired. As Kelly had mentioned, we had a fairly high number of those individuals and we didn't want them factored in here. But you can clearly see the decrease in reported unemployment as educational attainment increases. So in other words, as your formal education goes up, we observed unemployment going down. And lastly, I just really wanted to clearly display how clear the impacts of educational level were on a vast number of the challenges and questions that we asked within this survey. Is quite frankly one of the clearest kind of correlations that we could see across multiple variables. So on the top left, we have reported individuals that reported struggling with substance use by educational level. As the educational level increases, the percentage of respondents struggling with substance abuse decreases. That's up here. And then below that, we see reported food challenges. So anything where they had trouble accessing food or not getting enough food. And then this was broken out again by educational level. And we see a clear association with as your education level increases, we see decreasing challenges with accessing food. And then lastly, on the right, we see that financial situation question used again based on your level of education. And you can see that as your formal level of education increases, the more than enough money percentages pretty much go up at each step of the level. And likewise, the not enough money financial situation decreases at pretty much every step of the educational spectrum. So with that, I will be turning it back over to Kelly, and she'll be talking about our next 3 domains.
Thanks, Mike. So next we're going to explore neighborhood and built environment. Our questions within this domain primarily focused on housing and transportation. First, we'll look at the overall breakdown of the housing situation of our respondents, and then look at a few interesting findings around that. So most respondents reported renting their home, followed by home ownership. Cross-referencing with financial situation, 53% of respondents who own their home reported that they have more than enough money to pay for day-to-day expenses. In contrast, with 24% of respondents who reported that they rent their homes. There were 35 respondents, or 1%, who responded that they do not have housing. Of these 35 respondents, 57% also reported that they have a disability. Diving a little bit further into home ownership, this image looks at home ownership by race. The vertical bar here shows that 64% of white respondents reported owning their home, while anyone who selected any other race, only 23% reported that they own their home. The horizontal bars here break down that group of people of color. So there you can see that home ownership varies from a high of 43% in Asian respondents to a low of 17% in Pacific Islander or Hawaii Native. We also looked at home ownership by Hispanic Latino ethnicity, and we can see that people who reported their ethnicity as Hispanic or Latino were less likely to report they own their homes than respondents who are non-Hispanic or Latino. Looking further into the differences in home ownership, we look at respondents who reported owning their home by race and education attainment. This is one of the, for me personally, more moving charts. And I always get stuck on this slide because of the stark differences in home ownership value. So here you can see the results show vast inequities in home ownership by race, even when controlling for education level. For example, white respondents with a high school diploma or GED as their highest level of formal education were more likely to report owning their homes than Asian respondents with an associate's degree and Black respondents, and respondents of all other races with a bachelor's degree. So even though, to Mike's point, when we look at formalized education, increasing folks' ability to access money and some other things, we break that out by race, there are still vast disparities, even though there is an increase in all of the groups as they move along in educational attainment. So next, we're gonna quickly look at some health outcomes by housing situation. For these graphs, we grouped together respondents who reported living in a shelter or transitional housing with people who reported being unhoused. That group was most likely to report having asthma as well as anxiety or depression, followed by people who rent their homes and then by people who own their homes. However, I will note that in some age groups, people who own their homes reported slightly more anxiety and depression than people who rent. And lastly, just a few findings on transportation. Again, we saw the impact of education with 90% of respondents with a college degree reporting any use of personal vehicle, meaning they use a personal vehicle exclusively or in addition to other means of transportation, while 47% of respondents with no college degree reported any use of personal vehicle. Additionally, we observed that individuals with a disability were more likely to report challenges due to lack of transportation than respondents without a disability. We're going to move on to language access. While this domain can be explored more broadly to include general information access, in the survey, we focus on challenges related to spoken language. So on this slide, we'll look at English proficiency broken down by some demographics. On the top left is the question and response options about English proficiency. On the bar graphs here, we group the categories, quote unquote, not well and not at all, and excluded respondents who selected do not wish to say. So the graph with the vertical bars displays English speaking ability by Hispanic Latino ethnicity. We can see that the Hispanic Latino group was less likely to report that they speak English very well, though the majority of them, 78%, did report speaking English very well. And the bar graph at the bottom displays English speaking ability by race. So this shows that Asian respondents were the least likely to report that they speak English very well. Differences were observed when both the Asian group and Hispanic and Latino groups were disaggregated by country of origin, though there, to the point we've made several times, were not enough respondents to be able to share that disaggregation. The map shows percentages of respondents from each zip code that reported speaking English very well. So the darker the orange, the higher the percentage of respondents who reported speaking English very well in that zip code. Next, we cross-reference education and employment with English speaking ability. The graph on the left shows English speaking ability by education attainment. We can see that respondents who did not finish high school were the most likely to report that they speak English less than well. The graph on the right shows that respondents who speak English less than well were less likely to be employed. Here, we break down health outcomes by English speaking ability. This is a question we saw earlier about health outcomes. So for this analysis, we labeled anxiety or depression as mental illness and categorized the other conditions as physical illnesses. I'd assume that respondents with lower English proficiency would report more health conditions due to challenges associated with language barriers, such as not being able to access proper health care or connecting with other people for support. However, as demonstrated in this graph, this wasn't the case. There may be several explanations for this, and it's probably a combination of factors that can include lack of diagnosis due to lack of access to care, different views on health, particularly mental health, and healthier cultural practices. Next, we'll look at the social and community context ECDOH domain. So survey questions within this domain explored access to social supports, responsibility for young children, living with an adult who requires care, history of incarceration, and place of birth, which identifies respondents who moved to the US from another country or territory. To explore social support, we ask survey respondents how often they could rely on friends or family for 3 separate types of social support. And those are emotional support, having fun, and practical help. So with things like childcare or transportation, minor home repairs, that kind of thing. We use the same Likert scale rating that Mike discussed in the healthcare experiences section. And we had respondents rate the frequency of each of those supports, starting with never, which we assign the value of 0, to always, which we assign the value of 4. So on this slide, we can compare how participants rated their levels of social support with those who selected that they experienced challenges to accessing transportation, with those who selected accessing transportation is not a challenge for me. On the y-axis, you can see that the scale of these supports is listed as values as an average. And we can see that respondents who indicated they have transportation challenges rated their levels of support lower than those who indicated that they do not have challenges accessing transportation. So based on the way the question and responses are worded, that doesn't mean, it doesn't measure, excuse me, so much like the amount of support the individual receives, but more the adequacy of that support. So for example, there could be someone without transportation challenges who receives the same amount of support as someone without transportation challenges. However, they require more support often. So what they're receiving is not sufficient for them, even though it's the same as someone with no transportation challenges. Here's another graph comparing respondents who indicated that they live with an adult who requires constant care with respondents who indicated that they do not live with an adult who requires constant care. Here we can see that the respondents who do live with an adult who requires constant care report having needed social support less frequently than those who do not live with an adult who requires constant care. Next, we look at a similar graph, but comparing respondents who indicated that they have a history of incarceration with respondents who indicated that they do not have a history of incarceration. Here we can see that those with a history of incarceration reported getting support for their needs less frequently than those without a history of incarceration. And lastly, looking at health outcomes and social supports together, this graph shows that respondents who reported any physical illnesses and or anxiety or depression, but especially both, on average reported getting support for their needs met less frequently. So that concludes our results section of the presentation today. I do want to touch base on what's coming up next and how you can get active and involved in this work. So we do have our winter preparedness report as well as our focus group report coming out this year. The winter preparedness report is a release of findings from the City of Buffalo winter preparedness survey that we collected last year. And also in development is an interactive dashboard with the data from this survey, the health and wellness survey data that we presented today. And lastly, this QR code will take you to the community health assessment. We just opened up the survey. The process has just begun. We would love for everyone here to scan the code and take the survey when you have some time. Not a lot of time, 10 minutes or so, just to give you an idea of how long you'll need to be able to take the survey. We definitely appreciate you not only taking it, but sharing that information with others. And then the whole report, again, I want to give you our website to learn more about the work that we're doing and also to access the report. You can use this QR code or go to erie.gov/health-equity to be able to reach us around the work or around any opportunities to partner. So with that, that concludes the presentation. I'm gonna pop open the chat section to see if we have any questions in here. And feel free to ask questions if you have any. Or Jill, are you doing questions? How do you want me to?
I'm happy to field them, so at least I can filter them while you're responding, if that's okay.
Okay.
Okay. And to kick it off, so first of all, thank you so much to you and to your team for doing this again. I think it just reiterates what I said at the start of the talk, that it is phenomenal what you have accomplished in a very, very short period of time. The data is daunting without question, but what you've been able to pull together is tremendous. So congratulations to each of you. I think everybody should give a little clap on your screens right now to their office and to their team. So I guess the one question that I would have is that we at the university level, we don't want all of a sudden a million people coming at you with, I have this idea, I have that idea, and how can we partner? So can you give us an example or two of things that, because you only have so much bandwidth and look at how much you're already doing, like what are things that you would like to dig deeper in that you could use a little bit of extra help with, that maybe an investigator or their research group could jump in on?
That is an excellent question, and thank you, because um, we're still short-staffed. We have some folks that are out on leave, and we're still doing the work at the same time. The first, I guess, suggestion would be for folks to go to the actual report and look at the data that we've taken lots of time to put together. The way the report is written and presented, each page is meant to be a standalone piece, and so that data is already available in report form for folks to be able to access. So I I feel like most questions can be answered in the report that already exists. And if folks start there and kind of do that work, by the time they have an additional question, it, I believe, will be few and far between in comparison to not looking at the report and doing that part of the work. So one of the things we teach is do the work yourself and then come back for more questions. So whether it's community engagement, whether it's research, like go do the work yourself first, read the report, look at research, and then come with the questions. Same applies here. There's 324 pages worth of data and reports and charts and ideas, and start there.
That's great. Thank you. We do have one question from Dr. Kandel at UB. Thank you for a great presentation. Do you have any strategic plan to address these issues? How can we help? I'm working in improving outreach for stroke. It would be great to collaborate for community outreach too.
So we function within the Division of Public Health. And so within that space, there are other folks that do community outreach and engagement. The work that we do in outreach and engagement is primarily limited to survey collection and to like registrations for like mental health first aid. We don't do the traditional to tabling to table. Our goal is to interact with the system, which would be going back to community system, which is from a more of a macro standpoint, and to provide and create resources that allow others to continue to do the work that they do. So if you have an equity lens and you have the report that we spent a lot of time and effort on, you have the tools to do the work. You actually don't need us for that particular thing. So our goal is to train and educate and empower people to be equitable in their work without the Office of Health Equity. That means the Office of Health Equity needs to do the work in order to have resources and tools available for community members to be able to do, or to be able to use. And by community, in this case, I mean the UB community. And so the law requires that we analyze health outcomes and disparities. And again, we can't do them all. Our focus right now, in addition to mental health first aid, to be able to change the conversation around mental health, is developing a health and wellness. It's called Health to Your Home. And so we're working on developing that project to be able to reach the people that we're not reaching. And by we, the collective we, not the community health workers, like they are a part of the system, but who are the people that the community health workers are not able to reach. So a lot of our work is gap filling. We don't want to be duplicative. We want to make sure that whatever space we're in that space in a way that is innovative, that will yield data for us as an office. But the general health department does the general outreach and education. We don't focus on health behaviors as an office. However, our goal, the example I use is my issue is not whether or not a family is buying Pop-Tarts or Fig Newtons. My issue is why Pop-Tarts and Fig Newtons are the only options for that family to purchase food. So it's a different conversation. What community members do, they do. Our goal is to interact with the system in a way that gives community members better choices and options to choose from, so that no matter what they choose, it's a better option, instead of focusing solely on health behaviors. So I hope that answers the question a little bit.
Yeah, Kelly, can I jump in a little bit on
Sure.
that? Yeah, so the other thing, Kelly did throw up our survey for the community health assessment. And so this previous survey that we did, the one that we presented results on, is of course a great source of information for us as we head into the health department's cycle of community assessing the community. We'll get some additional data and information from this second survey, the community health assessment. It actually asks some questions that we didn't include in this previous survey, some focused on access to care, diving in a little deeper on some of those factors. And together, that information will be used to help create our community health improvement plan, our CHIP. So that really serves as kind of the health department's plan for strategically addressing the priorities in the community. And so we've started that process. And so we have hospitals already engaged in kind of planning that, and we will be bringing in community partners for all of that as well. And so, because there are so many issues and challenges for our community, we need to kind of help from the community to guide where we put our efforts moving forward. So that's kind of how this previous survey, the other additional CHA survey, will be used to kind of guide the future and the strategic plan with health department resources moving forward. So just adding that.
And the report itself looks much like the presentation. And so the slides will be available, but also, not to, labor the point, the report itself really gives you more information, more detailed information. The exact same charts you saw here are presented on one of those pages in the report. And so that link is in the chat for you to access.
Can I ask one last question? It's obviously a huge lift, the data that you gather, the report that you put together. And actually, I think you and I have spoken, the presentation was phenomenal this year because it really makes a lot of data very digestible. And so it's extremely polished. So is it something, I was part of a conversation last night and everybody was talking about longitudinal data. So is this something that you plan to repeat year after year, this same question, so that you can start to see trends? And if somebody on this call or at the university had a recommendation of a question that could benefit, like maybe part of the research that they're trying to do, like Dr. Kendall was talking about, like how to get awareness out for stroke, or even like assess some of that, could they reach out to potentially ask if you could include a question or two?
And so I am first drafting this out loud, so don't look at Mike because he may be not happy with what I'm about to say. But no, the reason this survey was important was because we didn't have anything in the aftermath of COVID, and there was nothing with an equity focus. We, the Office of Health Equity, are now responsible for the community health assessment. And so that really will be the benchmark year after year data set that we'll be looking at. And yes, some of those questions may change over the years, depending upon which direction health leads us. But that really is, for me, the direction that we're looking to go, not to repeat the survey that we spent a lot of time on, but to focus on the community health assessment and the community improvement plan, so that we have and now that it's on a 5-year cycle instead of a 3-year cycle, it allows us to be more strategic, to the point of the question earlier, but also to be able to follow the data from one place, even though, you know, outside looking in, the health department is the health department, but the epidemiology department within the health department functions differently than my epidemiology team. So they look at data differently than we do. And so moving forward, again, the community health assessment will be that that data point to be able to track the work moving forward.
Well, thank you to you for your leadership. Thank you to your team for all the great work that's being done. And we appreciate you taking the time to do this again for us. But you can obviously tell, even just with today, and Kelly, I'll share a summary with you afterward, but we had 70 different people show up for this today. And so I'll give you a list of who was here, but thank you to everything. Thank you to all of you for all that you're doing. And we just so appreciate your collaboration and everything that you do, especially for the university and your leadership role on the Health Equity Research Institute as well. So,
Thank you.
all right.
And, Brian, to your point, yes, I saw that pass by. Thank you so much, Jill.
All
Thank
right.
you everyone for being in.